Welcome, everyone. My name is Ted O'Connell. I'm one of the authors of Crush Step 1, the Ultimate USMLE Step 1 Review. This is the second edition of the book, and we're going through it chapter by chapter. This is part 6 of the Cardiology chapter. We're going to start by talking about pathology, beginning with congenital heart disease. There are many congenital heart diseases, classified broadly into two categories. First, cyanotic heart disease, and second, acyanotic heart disease. Cyanotic heart diseases are characterized by right-to-left shunts, where deoxygenated blood is put into the systemic circulation with subsequent early cyanosis. Acyanotic lesions have left-to-right shunts, causing oxygenated blood to be circulated back into the lungs and therefore not causing early cyanosis. Definitive treatment for cyanotic lesions is almost always surgical. It is necessary to remember the 5 cyanotic heart diseases. A common mnemonic is the 5 T's of truncus arteriosus, transposition of the great vessels, tricuspid atresia, tetralogy of Fallot, and total anomalous pulmonary venous return, or TAPVR. Another way to remember this using the 5-finger method will be described. 1 finger up. Truncus arteriosus. 1 finger because there is 1 common vessel. Embryologically, the truncus arteriosus should divide into the pulmonary trunk and aorta. Failure to do so results in a single common artery leaving both ventricles. 2 fingers up, fingers crossed. Transposition of the great vessels. Fingers crossed because they are transposed. The aorta and pulmonary artery are transposed, switched. The aorta comes off the right ventricle, whereas the pulmonary artery comes off the left ventricle. This causes 2 completely separate circulations, whereby the right ventricle is pumping deoxygenated blood to the body through the aorta, which returns to the right ventricle. The left ventricle is pumping oxygenated blood to the lungs through the pulmonary artery, which returns to the left ventricle. For the infant to survive, a shunt that connects the 2 systems must be present to bridge the 2 circulations, such as patent ductus arteriosus or patent foramen ovale, an opening between the right and left atria. Prostaglandin E, or misoprostol, can be given to ensure that the ductus arteriosus remains open. A commonly tested association on the USMLE of infantile transposition is maternal diabetes. 3 fingers up, tricuspid atresia. 3 fingers for tricuspid. Absence of the tricuspid valve leading to no connection between the right atrium and right ventricle. Because the right ventricle is not receiving blood to pump, it is hypoplastic, that is, very small and underdeveloped. An atrial septal defect and a ventricular septal defect must both be present to maintain blood flow. From the right atrium, the blood must flow through the atrial septal defect to the left atrium, to the left ventricle, and through the ventricular septal defect to the right ventricle to allow access to the lungs. 4 fingers up, tetralogy of Fallot. 4 fingers for tetralogy. The tetra prefix means 4 for 4 abnormalities. This is a developmental defect in anterosuperior displacement of the infundibular septum, leading to 4 abnormalities that can be remembered with the prove mnemonic. Prove that they have tetralogy of Fallot. The P is for pulmonic stenosis. The degree of stenosis correlates with prognosis. R is for right ventricular hypertrophy. A consequence of the high resistance against blood flow out of the right ventricle from the pulmonary stenosis. It leads to a boot-shaped heart on radiograph. O for overriding aorta, and V for ventricular septal defect. The pulmonary stenosis causes high resistance out of the right ventricle, causing right ventricular hypertrophy and deoxygenated blood to instead move into the left ventricle through the ventricular septal defect, but also directly from the right ventricle to the aorta, because the overriding aorta often has connection to both ventricles. Patients suffer cyanotic spells called TET spells. Children learn to improve their cyanosis by squatting, which increases systemic vascular resistance, or afterload, by putting pressure on the femoral arteries, leading to comparatively less resistance in the pulmonary circulation and therefore more blood going into the lungs through the stenotic pulmonary valve. This is the most common and most commonly tested cyanotic congenital heart disease. 5 fingers up, total anomalous pulmonary venous return. 5 fingers for the 5 words of total anomalous pulmonary venous return. Normally, the pulmonary veins drain into the left atrium. In total anomalous pulmonary venous return, the pulmonary veins drain into the systemic venous circulation. It is called total because none of the pulmonary veins correctly return to the left atrium. A shunt between the 2 atria, such as an atrial septal defect or patent foramen ovale, must be present, or oxygenated blood will never reach the left heart. The acyanotic heart defects include ventricular septal defect, which is the most common, atrial septal defect, and patent ductus arteriosus in descending order of frequency. These cause left to right shunts, whereby oxygenated blood is put back into the right heart. Although these do not typically cause problems in the neonate, eventually it can lead to Eisenmenger syndrome. With a left to right shunt, the right heart receives additional blood, which is pumped through the pulmonary circulation. This additional flow causes hypertrophy of both the right heart and the pulmonary vasculature. The hypertrophy and subsequent intimal narrowing of the pulmonary causes increased pulmonary resistance. Eventually, the pulmonary resistance increases enough that the left to right shunt now becomes a right to left shunt, leading to deoxygenated blood being shunted into the systemic circulation with resulting cyanosis. Lastly, coarctation of the aorta is a narrowing of the aorta most strongly associated with Turner syndrome and bicuspid aortic valves. And remember, Turner syndrome is 45XO. Narrowing in coarctation of the aorta causes increased afterload for the left ventricle, resulting in left ventricular hypertrophy. Because the narrowing is after the aortic arch vessels, there is no impediment to perfusing the upper half of the body, the head and upper limbs. Long-standing coarctation can lead to dilation of intercostal vessels that act as collateral circulation, meaning that the blood flows in the reverse direction from intercostal vessels to aorta to allow blood to reach the legs. This causes a characteristic rib notching appearance on radiograph due to erosion of the ribs. Classic findings are weak femoral pulses and differential cyanosis. In neonates, the coarctation is preductal, meaning the narrowing occurs before the ductus arteriosus. Therefore, the lower half of the body can be cyanotic due to deoxygenated blood from the pulmonary artery being shunted through the ductus arteriosus into the aorta. Because the narrowing is after the aortic arch, the upper half of the body is perfused normally with oxygenated blood from the left ventricle. Pink top, blue bottom equals differential cyanosis. In children and adults, the diagnosis can also be made by measuring a systolic blood pressure difference between upper and lower extremities, and this difference needs to be more than 10 millimeters of mercury. That's the end of this section. In the next, we'll pick up with atherosclerosis.